Hello students. Now coming to the second part of disease of dental pulp. Till now we have covered the etiology of the dental pulp and the classification of dental pulp. Now coming to the detail in the conditions of disease dental pulp. So this is a flow diagram or secule of pulpal disease in which you can see that whenever there is a normal pulp and it is exposed to a noxious stimuli, then it may lead to first stage, that is your reversible pulpitis. Now, if the reversible pulpitis is not treated, then it may progress to irreversible pulpitis. Irreversible pulpitis is of further subtypes. It may be of chronic hyperplastic pulpitis. It may be your symptomatic or symptomatic irreversible pulpitis or asymptomatic irreversible pulpitis, or it may progress into internal resorption. And all of these can also lead to pulpal necrosis. Similarly, if the stimuli is of low grade and it causes degenerative changes in the pulp, then it may lead to calcific degeneration or calcific metamorphosis of the pulp. Coming to the reversible pulpitis, it is also called as hyperemia or hyperactive pulpasia. I have also asked the question in your previous week regarding the difference between your hyperemia and irreversible pulpitis. So reversible pulpitis is also called as hyperemia or hyperactive pulpasia. In this, there is a mild to moderate inflammatory condition of the pulp caused by noxious stimuli in which the pulp is capable of returning to the uninflamed state following removal of the stimuli. Etiology, it may be because of trauma, thermal shock, excessive dehydration, chemical irritations, like galvanism, excessive orthodontic forces, slow progressive chronic lesions, low vascular congestion, circulatory disturbances. Irritant that causes hyperemia or mild inflammation in one pulp that may produce secondary dentine in another if the irritant is mild enough or if the pulp is vigorous enough to protect itself. Symptoms of reversible pulpitis. There is a short, sharp pain lasting for a moment. The moment you remove the stimulus, the pain goes off. It is a momentary pain. As all of you know that the only sensation that is felt by the tooth is your pain. Does not occur spontaneously. It needs a stimulus, most often brought on the cold, then hot food or beverages. Diagnosis is made by the study of the patient's symptoms and by clinical test. Pain of sharp quality lasts for a few seconds and generally disappears when the stimulus is removed. Cold, sweat, or sore usually causes the pain. Sometimes the pain may become chronic and may continue for weeks or even months. Visual examination or patient history, you can see there is a presence of caries, restoration of fractures or traumatic occlusion, and percussion, rex normal to the percussion, palpation and mobility. Radiography, there is no radiographic changes, absolutely normal lamina dura. Vitality test, hyperalgesic pulp respond more readily to the cold stimulus than normal tooth, as there is an increased excitability of the A delta fibers. Histopathology, you can see there is a mild to moderate inflammatory changes limited to the area of the involved dentinal tubules. There may be a repetitive dentin formation, disruption of odontoblast, dilated blood vessels, extravasation of edema, and chronic inflammatory cells. Differential diagnosis. It can be differentiated from irreversible pulpitis because of the characteristic symptom of sharp onset of pain lasting for a few seconds. Thermal test is usually helpful in locating the affected tooth as reversible pulpitis responds readily to the cold. Pulp electric EPT is an excellent corroborating test also. Treatment, best treatment of reversible pulpitis is prevention. Periodic care to prevent the development of caries, early restoration if a cavity has developed, use of cavity varnish or cement base before insertion of restoration. That's why it is very important to give a base or sub base underlying deep cavity. Care in cavity preparation and polishing. Then prognosis is favorable if the irritant is removed early enough. Otherwise, it may progress to irreversible pulpitis if not treated. Irreversible pulpitis is a persistent inflammatory condition of the pulp, symptomatic or asymptomatic nature, with the pulp becoming incapable of healing. Now it is of further two types. It may be a symptomatic or acute irreversible pulpitis or chronic asymptomatic irreversible pulpitis. Most common etiology is bacterial involved with the pulp. Chemical or thermal mechanical injury also. Reversible pulpitis, if not treated, may deteriorate into the irreversible pulpitis. Symptoms, early stages, paroxysms of pain may be caused by sudden temperature changes, particularly cold, sweat, sweet, or acidic foodstuffs. Pressure from packing food into a cavity and on lying down, which result in the congestion of the blood vessel or the pulp. Pain persists for several minutes to lingering after the removal of the stimulus. Pain is described as sharp, piercing, or shooting, or it is generally a severe type in nature. Change in position, that is on bending or lying down, increases the intrapulpal pressure, resulting in a pain. Referred pain to the adjacent tooth to the temple or sinuses when an upper posterior tooth is involved, or to the ear when a lower posterior tooth is involved. Later stages pain is severe, described as boring, gnawing, or throbbing. Nocturnal pain, which is intolerable despite their efforts at analgesia. Apical peritonitis is absent except in later stages when inflammation extends to the periodontal ligament. Diagnosis is made by studying the patient's symptoms and clinical test. Nature of the pain, mild to severe or even excruciating throbbing pain. It's generally diffuse or readily not localized with the patient. Patient pain lingers after the primary irritant has been removed. Pain may be referred to other areas also. On visual examination, you can see the deep cavity extend to the pulp, decay under restoration. Percussion, there is a tenderness, implies an increase in interpulpal pressure as a result of the hyperactive exudative inflammatory tissue. Widening the pedial space without percussion, tenderness, implies a non-painful state. Radiograph may not showing anything of significance, may disclose an interproximal cavity or caries, and which is your undermining the integrity of the pulp. Vitity test, thermal test may respond in the same as reversible pulpitis, but pain may persist after stimulus has been removed. Cold will tend to leave the pain in advanced stages of pulpitis because it has a contractile effect on the remaining central or apical function of vascular bed, reducing the interpulpal pressure. That's why sometimes a patient come to you and with a pack of ice applying on his tooth and saying that it is helping him or her in relieving the pain because of decrease in the interpulpal pressure, because that decrease in the there is a congestion in the vessels of the pulp leading to a decrease in interpulpal pressure. EPT, response to less current, may be expected in early stages because of low threshold of peripheral A delta fiber. As the tissue become more necrotic, more current is required. This test may not be a diagnostic in advanced cases of acute pulpology because the mixed response, particularly multi-rooted teeth. Histopathology, you can see acute and chronic inflammatory changes, continuous vasodilation, edema fluid, microabscesses, odontoblasts are destroyed, all of the acute and chronic inflammatory changes. DD or differential diagnosis, symptomatic stage, exposed pulp exhibits little asymptomatic stage, exposed pulp exhibits little or no pain except when food is packed. Hence, more current is required to elicit a response to EPT than in a control tooth. Then come to the early symptomatic stage, and less current is required to elicit a response in EPT than normal. Pulp is abnormally responsive to the cold, induce or spontaneous pain that occur in sharp and piercing in nature. In the later stages, symptoms may simulate those of acute alveolar abscess. Abscess is differentiated from irreversible such that abscess will have a swelling. The tooth is tenderness on percussion, and it has got a mobility. Tooth has got a mobility, lack of response to the vitality test, and systemic conditions of features such as fever or nausea. Treatment is your complete removal of the pulpectomy, that is called your root canal treatment, and placement of intercalated medicament to act as disinfectant or obtundant. And extraction should be considered if the tooth is unrestorable. Prognosis favorable if the pulp is removed, the tooth undergo proper endodontic therapy and restoration. Then coming to the another condition of the pulp, disease of the pulp, that is called chronic hyperplastic pulpitis. It is a productive pulpal inflammation due to an extensive carious exposure of the young pulp, characterized by the development of granulation tissue covered by at time with epithelium resulting from long-standing low-grade irritation. This is characteristically seen in young patients where there is a patient body has a good immune response and there is a low-grade infection or irritation. So there you can see a pulp polyp. Etiology: slow progressive exposure, large open cavity, and rank resistance pulp, and low grade stimulus. So symptoms less is a condition. It is a symptomless condition except during mastication and pressure on the food bolus may cause discomfort. Treatment: diagnosis generally seen only in teeth of children and young adult, and there is a um, soft tissue mass coming from the pulp chamber into the cavity. So there you can see a radiograph. There is a large open cavity with direct access to the pulp chamber. Thermal test may respond feebly or not at all because the pulp has completely died and become necrotic. Surface is covered by stratified squamous epithelium, and the pulp tissue chronically inflamed tissue you can see, and it can be differentiated from the other conditions very easily. And this order must be distinguished from gingival polyp, where you can see the that mass. When you trace the stalk of that soft tissue mass, it comes from interdental gingiva in case of gingival polyp, while in case of pulp polyp it directly coming from the uh, pulp chamber. Treatment is simple, that is your removal of that soft tissue with a periodontal root or spoon excavator, and the bleeding can be controlled with pressure. Pulp tissue of the chamber is then comfortably removed, and dressing of formicosole is sealed in cavity, sealed in contact with radicular pulp tissue. Radicular pulp is then extracted at later visit or at the same visit also. If time permit, entire procedure can be completed in a single visit. Prognosis of the pulp is unfavorable, but the prognosis of the tooth is favorable after the endodontic treatment and adequate restoration. Then coming to the another condition, another disease of the pulp, that is called internal resorption. Here you can see a pink tooth also. It is an idiopathic, slow, or fast progressive resorptive process occurring in the dentine or the pulp chamber of or root canals of the teeth. The cause of internal resorption is not known, but such patients often have a history of trauma. So it is a idiopathic in nature also. Internal resorption in root of a tooth is asymptomatic. It is also called pink spot or pink tooth of Mummery. Reddish area representing the granulation tissue showing through the resolved area of the crown. Histopath: internal resorption is a osteoclastic activity. Resorptive process is characterized by lacuna which may be filled in by osteoid tissue, presence of granulation tissue, multinuclear giant cells or dentinoclast may be seen. Pulp is chronically inflamed. Metabolism of the pulp, that is transformation of the another type of tissue such as bone or cementum may occur. Diagnosis may affect either the crown or root of the tooth, or it may be extensive enough to involve the tooth. Most readily seen in the maxillary anterior tooth. It is a slow progressive extending up to 1 to 2 years. And in radiograph, you can see a change in the appearance of the wall in the of the root canal with a round or ovoid radiolucent area. That is called the ballooning of the root canal. Differential diagnosis: it when internal resorption progress into periodontal space and perforation of the root occur, it is difficult to differentiate it from external root resorption. Resorptive defect is more extensive in the pulpal wall than on the root surface. So here you can use a cone shift technique or slob rule to distinguish it from the external root resorption. Simply, if you change the angulation of the cone at another mesial or distal angulation, the defect or the ballooning effect you can see again in case of your internal resorption, while in case of external root resorption it is well differentiated, or it is the outline of the root canal and the defect are separate. Treatment involves extirpation of the pulp, and we have to give calcium hydroxide dressing for 2-3 weeks before proceeding to obturation. And thermoplastic upper techniques would be used to fill the root canal space after proper cleaning and disinfection of the root canal. Prognosis is best before perforation of the root or crown, and if the perforation occur, then the prognosis is guarded. Then coming to the another condition that is called pulp degeneration. It is generally present in teeth of older people, may also be seen in teeth of younger people as a result of persistent mild irritation. As I have already discussed in the sequel of the um, pulpal disease, that if it may pulpal, it depends pulpal the aninoxous stimulus, and can lead to a pulpal diseases such as irreversible pulpitis, or it may can also lead to the another type of pulpal disease that is called calcific metamorphosis, depending on the response, host response or host immunity to respond to a stimulus. If the Now the early stages of pulp degeneration shows no signs or symptom in this case, but as the degeneration progresses, the tooth may become discolor and the pulp will not respond to stimulation. It is of three types: calcific, atrophic, and fibrous degeneration. Calcific degeneration, the part of the pulp is replaced by calcific material that is called pulp stones or denticles. Calcification may occur either within the pulp chamber or root canal, but it is generally present in the pulp chamber. Here you can see in the radiograph also there is a the red circle in the inside the pulp chamber. You can see a radio opaque rounded mass that is called pulp stone or calcific degeneration. So it may be classified according to the position of free denticle. It is if the pulp stone lie freely in the pulp chamber as in the previous diagram. Attached if it is attached to the dentine walls. Embedded if it is completely encircled by the dentine. And depending on the histological picture, it may be true denticle or the false denticles. Degeneration of complete pulp space may occur as a sequel to the traumatic injury that is called calcific metamorphosis. As here you can see in the radiograph, there is a complete obliteration of the root canal space in the center incisor. The teeth or tooth may remain asymptomatic and exhibit a discoloration of the crown because of the obliteration of the pulp chamber, or because of the more formation of the dentine or calcific material inside the pulp chamber. Then coming to the atrophic degeneration, it is mostly seen in the older peoples where fewer steel is present, in the intercellular fluid is increased, and the pulp tissue is less sensitive than normal, and no clinical diagnosis exist. So there is a complete degeneration of the pulpal tissue in case of your atrophic degeneration. Then coming to the fibrous degeneration, characterized by replacement of cellular elements by fibrous connective tissue. It is a pulp is a leathery fiber in appearance. No distinguished clinical symptom to aid in diagnosis. Then coming to the another condition of the pulp that is called necrosis of the pulp. Here there is a death of the pulp. It may be partial necrosis or is a total necrosis, depending on whether part of the entire pulp is involved or whole pulp is involved. It is a sequel, or it is a caused by as a sequel to the inflammation following a traumatic injury in the pulp, and it can be caused by noxious insult injuries to the pulp, such as chemical irritations. And the types of necrosis, as you must be knowing in your general pathology classes also, it is of a coagulative necrosis or a liquefied necrosis. Coagulative necrosis, soluble portion of the tissue is precipitated or is converted to solid mass. That is also called a casein type of necrosis, cheesy mass. And liquefative, where there is a because the proteolytic enzyme, the whole tissue is converted to softened mass and liquid amorphous debris. Now these are can be distinguished only by the histopathological picture. Radiographic, clinical, you cannot distinguish which type of necrosis have occurred in the tooth. But the good thing is that the treatment is same for both of the type of necrosis. That is your root canal treatment, which is your complete extirpation of the pulp. So these are the end products of the pulp decomposition and intermediate products of the pulp decomposition. Symptoms: no painful symptom in case of pulpal necrosis because there is a no nerve vessels inside the pulp chamber to experience that pain. Discretion of the tooth is first indication because there is a complete loss of vascular supply. So now the pulp, the tooth is little bit discolored. Tooth lacks its usual brilliance, luster, and translucency. Presence of necrotic pulp may be discovered only by chance sometimes because the tooth is asymptomatic. Teeth with partial necrosis can respond to thermal changes owing to the presence of vital nerve passing through the adjacent inflamed tissue. Diagnosis: pain is absent in tooth with total necrosis, thickened PDL space, swelling, mobility, and response to percussion palpation are negative. There is no response to vitality test as well. Histopath: here you can see there is a cellular debris and micros may be seen in pulp cavity. Peripheral tissue may be normal, slightly evidence of inflammation. Treatment is root canal treatment. Prognosis is favorable if endodontine treatment is done. This is a chart comparison showing the comparison of the or differential diagnosis of the all the diseases of the pulp. Here you can go through this chart as I have already discussed all the features. So to conclude, pulp is a formative and highly resistant organ of the tooth. Pulp is among the most densely invertebrate and vascular tissue in the human body, and microcirculation systems serve several essential roles in maintaining the vitality of the pulp. Both these systems are critically important in maintaining the homeostasis of the dental pulp. The value of pulp as an integral part of the tooth, both anatomic and functional, should be recognized, and every effort must be made to conserve it. Thank you so much.